Bismillah ar-Rahman ar-Rahim. We started today X-ray session. This patient is 60-year-old male, heavy smoker, presented with shortness of breath, fever, cough, more than 1 month duration. And this is his chest X-ray PA. Obviously you see this is a chest X-ray with a homogeneous opacity obviously in this right mid zone, obliterating the heart border. This is the heart border, and this supposed to be, this is the heart border. It's not clear. Therefore this consolidation, this opacity is what is attaching to the heart, is just near to the heart. And because the heart is anteriorly situated, not in the middle, not in the back, therefore this lesion in the lung is anteriorly situated. And this area that's silhouetting with the heart, obstructing the border, right border of the heart, is area of the middle lobe. That's the pulmonary artery. This is a non-homogeneous opacity with air bronchogram. You see these dark things, air bronchogram in it. Clinically there is a bronchial breathing anteriorly in the right anterior part of the chest, lower down, not in the apices, not in the upper zone, in this area there is a bronchial breathing, indicating that this lesion is what? Pneumonia, consolidation. And there is also obliteration, not obliteration actually, opacity on the lower part of the lung. It is behind the heart, because the heart border is what is clear. Therefore this lesion is not anteriorly situated, it is posteriorly situated, and we have the posterior situated is what? Is the left lower lobe. CT scan of this patient show that's the window type of CT scan. That it mean by window that we omitting the tissue, the normal tissue, by increasing the density of the CT scan. And this is the apices of the lung. You see there is element of old fibrosis in what? In the left apices. This is the trachea, this is the vertebrae, this is the upper lobe, this is the apices, this is the upper lobe also. There is element of fibrosis there. And if you go down, still we are in the upper lobe, trachea. This is the arch of aorta, and this is arch of aorta also. This is the trachea, and here we are reaching the carina. Still we have arch of aorta, still the arch of aorta, the carina there is obvious. And this is the pulmonary artery, the main pulmonary artery, with the left branch and right branch. If at this point we starting get some opacity there in the anterior part of the lung, right lung. This opacity increase, you see it increase with air bronchogram. This is air bronchogram all over the lesion. And as we said, because the anterior part of the lung in the right side is the middle lobe, therefore this is the right middle lobe, consolidated and collapsed with air bronchogram until there is disappear. Also we find that there is starting element of consolidation in the left lower part. This is the left lower part, this is the left lower lobe, with a consolidation with air bronchogram all over this lower part, left lower part. Therefore this patient got pneumonia in the anterior part of the right and the middle lobe, and in the lower part in the left, in the left lower lobe, pneumonia. What could be the type of pneumonia is this? This is, you see, this is the pulmonary artery, this is the aorta, this is the rounded is aorta, this is the pulmonary artery. Just cuddling the aorta. Cuddling means يحضن. This is the aorta, this is the thoracic aorta also, and this is the pneumonia. This is a pneumonia with air bronchogram. Pneumonia with air bronchogram. What could be this pneumonia? Bilateral pneumonia, bilateral lobe pneumonia. What is the cause of this pneumonia in this chronic bronchitic patient? Pneumonia is acute inflammation of the lung parenchyma. It is the most common killer in a human being as infection. Pneumonia, some say that it kills nearly 100,000 every day. That's pneumonia, especially in extreme age, elderly and young patient. And pneumonia, this is actually a lobar pneumonia. Lobar pneumonia. What is the cause of lobar pneumonia? Infection, streptococcal pneumonia, or pneumococcal pneumonia. This is infection, and this is also infection there and infection there in the patient. Probably he is immune compromised. Probably probably if he got, especially if you got any element of immune compromise, you will get a pneumonia widespread. Because he is elderly and we are in the summer part, therefore most probably this is what? Legionella? Yes, and in the lower part you should think of Legionella. Usually pneumonia occur in the winter time, in the spring, and because is now Iraq is in the summer, therefore this pneumonia could be what? A Legionella pneumonia. Usually Legionella pneumonia have multiple lobe involvement. The patient mostly elderly. It is with multi-system. I mean the patient got what? Got blood urea elevated, got sodium low, got pericarditis, got GIT, diarrhea, vomiting, etc. This is a pneumonia. Actually, we didn't find these things in this patient, in our patient. Therefore, could be tuberculosis? Yes, could be tuberculosis. What they call it is the lower lobe tuberculosis. This is the hilum. Anything below the hilum, if you get TB below the hilum, this is lower lobe or lower part of the lung tuberculosis. But usually this is occur in young patient. Usually in young patients below 40. Could be this is a tuberculous lesion. Yes, could be a tuberculous lesion. Actually we start this patient on third generation cephalosporin, ceftriaxone, and clarithromycin. What is clarithromycin?
Microlode antibiotic.
It is macrolides. Actually, it's just one of the erythromycin antibiotic, macrolides, clarithromycin. It is effective, but remember that this clarithromycin might what suppress what? Tuberculosis, because it is considered the third or the second line of anti-tuberculosis.
Actually a static.
It actually in erythromycin in high concentration is cidal, in low concentration is static, and therefore, but the patient get response. I mean, he is become well for the last 3 days. He is become better, and his tachypnea has become less. His fever disappear. We think that this is probably what? A pneumonia, a simple pneumonia, not that Legionella and not that of tuberculosis. If there is no response and the patient deteriorating, we should think probably of TB or Legionella. Anatomy of the lung. how we define the lobes in the PA view. We draw an imaginary line from D4, this is D4, right away to the axilla, then we bring it back to the lower part of the chest, hitting the diaphragm medially. This is an imaginary oblique fissure. Okay?
From second discuss
From D4 till the axilla and back to the heart. This is considered to be oblique fissure. And from the 6 horizontally till the hilum, this is called what? Transverse fissure. This is triangle. This is triangle. This is triangle. Triangle attaching the base of it on the heart. As in this patient, pneumonia of this lobe is obliterating, obscuring the right border of the heart. Therefore, this lobe is anteriorly situated, because we know the heart is anteriorly situated in the chest. Therefore, this is what? The right what? Right middle lobe. The rest of the anatomy of the lung that's attaching, hitting the diaphragm is the right what? Lower lobe. Anything above the transverse fissure is what? Right upper lobe. The same thing is in the left side, but instead of right middle lobe, we put what here? Lingula. Because the bifurcation of the trachea, this is the trachea, bifurcate to the left and to the right. The distance here is 5 centimeters. Before bifurcation, it bifurcate to 2. This is left lower lobe main bronchus, and this is the left upper main bronchus. It divides to 2, left upper and what? And lingula. This is the bronchus to the lingula, and this is the bronchus to what? To the upper lobe, the left upper lobe. This is lingula. Consider this is the heart. This right side, which is 2.5 centimeter, right main bronchus, divided to right upper lobe bronchus, then go 1 centimeter, we call it the bronchus intermedius, and then anteriorly give what? Right middle lobe bronchus, and the continuity is what?
Right lower.
Is the right lower lobe bronchus. Therefore, this is the right middle lobe area, this is the upper lobe area, and this is the lower lobe area, and the same in what? In the left side. Clinically, if the bronchial breathing mainly in the back and lower, this is the lower lobes. I mean, you hear the bronchial breathing less anteriorly, but it is mainly and posteriorly situated, and in the lower part you should think of lower lobe pneumonia. If the bronchial breathing is mainly anteriorly, you hear it better. This is right middle lobe pneumonia. As in this patient, we hear in the right side mainly anteriorly, but in the left side we hear it bronchial breathing mainly what? Posteriorly. It is the lower lobe in the left and right middle lobe in the right. Pneumonia side. Can you tell me if a pneumonia occur in the upper part, in the apex, pneumonia? What is the differential diagnosis of pneumonia?
TB. Pulmonary TB.
Yes, first of all TB. Second, Klebsiella. The third is pneumococcal pneumonia. Fourth, malignancy can be mimic. If pneumonia occur in this part of the lung, on both sides, just like wing, what they call this?
Bronchial.
It is a consolidation, and clinically it is pneumonia, and in the mid zone, just like a wing, جناح. Could be a pneumococcal pneumonia. Could be what? Could be a pneumocystis carinii. Okay. Any pneumonia occur in the lower part. If it is unilateral, could be a pneumococcal pneumonia, could be a tuberculous pneumonia, could be a legionella pneumonia, but legionella pneumonia usually on both sides, and it affects the male lobes, and the patient is seriously ill. There is multi-organ symptoms and signs. The patient with legionella got what? Pericarditis, pericardial effusion. He got acute renal failure. He got low sodium. He probably affecting the brain, get confusion, even coma. And he got a pneumonia in the lower part. There is, if the patient immune compromised and he was on steroid or on Imuran or etc., and he got pneumonia in this area, you should think of pneumocystis carinii, and they call it now, what they call it? Juvali. And it is not a bacteria, it is what? It is a fungus. Okay. If you see it's in the lower part, this pneumocystis carinii doesn't hit the lower part of the lung. It hit the lower part of the lung at the end. I mean, the patient before dying probably come down into the lower part of the lung. This is a pneumonia. In this patient, a simple pneumonia, but severe because they're affecting two lobes. And still we are looking for tuberculosis in this patient, because first of all he is elderly, secondly he got fibrosis in the left abysses, thirdly he is a smoker, and he have got comorbidity that might be affected by tuberculosis. Any question?
طلعوني هذا البقال هسه خلي لي الافلام خلي الجواب الله عليك.
This patient is a 28 female. She is very tired, weight loss, shortness of breath, dry cough, and sometimes hemoptysis. And this is her chest X-ray actually. The X-ray is dark, and it show actually, because it is dark, is not showing anything actually. This is we did a CT scan of this patient, and you see the window of the scan, window face of the scan, and you see this is the trachea, this is the thyroid, this is trachea, this is the trachea, this is still we have in the trachea still. We go back, this is the upper lobe, until we get the carina, this is bifurcation, carina. Down pillow. Surprisingly, this patient got a mass in what? In the left breast. This is the mass. In the CT scan is mass. Actually, clinically, we found a mass in the left breast, that solid mass, painless mass, 5 by 7 diameter mass, occurring in the left upper lateral part of the breast. And we did the fine needle of this mass. Actually, I did the fine needle of this mass, and it turned to be CA what? CA breast. You should be careful. Any lesion, any complaint in the chest in a female, you should go right away to what? To examine the breast and examine the legs of that patient, the female patient. Breast to exclude cancer, and DVT to exclude it when you examine legs, because you might get pulmonary embolism and you might get lymphangitis carcinomatosis as in this patient. This is the tissue face of the CT scan of the same patient. You see, this is the apices, and they still in the upper part there is a lot of nodes infiltrating, masses, small masses infiltrating. If you go down, you get it clear in this area, infiltrating masses, small masses. This is a clear cut infiltration, and this is probably secondaries, either hematogenous secondary from the breast cancer or lymphangitis carcinomatosis. You see, this is actually the bone affection. This is the bone deposition of malignant tissue in the bone. What is this? What is this? This, you see something shining from the back of from the dark, and it's become clear. What is this? If you see such picture in the CT scan, tissue face, usually the tissue face appear like shining. This is the dome of the diaphragm. This is the right dome of the diaphragm. This is become the dome of diaphragm is clear. And here is the dome of what? Left diaphragm starting. As we said, because the left dome of diaphragm is below the right nearly 3 to 5 centimeters. There is also, this is a view in the liver, there is a deposition in the liver area. This is a deposition of cancer in the liver, deposition of cancer in what? In the bone. Therefore, this unlucky patient got what? Got CA breast and advanced with hematogenous metastasis, and this is the malignancy actually. CA, this is the breast. This is the upper lateral, left upper lateral, with there is axillary tail there. The number of malignancy, the percentage of malignancy in this type of in this site of the breast is what? 46% of the total. The areola is 20%, and the nipple and the middle and the lower, both lower, between 10 to 12 each one. This is the common site of malignancy in the breast. Which female is more liable to breast cancer?
Family history.
Yes, usually they got family history. There is sometimes familial cluster of malignancy.
Non-lactating female.
Smoker female.
A smoker female, if she smokes, she get breast cancer. If she drinks, she get breast cancer too. Sorry? Nullipara female.
Contraceptive.
Use probably of contraceptive pills. Probably this is and those non-lactating. Obesity is a risk factor in malignancy of the breast.
early menarche
This is a CA-breast causing lymphangitis carcinomatosis. You see, this is the typical lymphangitis carcinomatosis, and deposition in the bone and deposition in the liver where there is a distal metastasis.
حسن 25 دقيقة بس.
ما صارت؟
26 دقيقة.
نوقف؟
نوقف. وين نوقف؟
نسوي لنا سيشن ثاني؟